Good evening, Dr. Anurag, sir. Sir, good evening, sir.
You mute. Sir is muted.
I don't know. Anurag sir is joined now. I don't know.
Muted.
Sir is not able to hear us. Sir is
Yeah,
in
yeah.
mute mode.
Hello. Good evening.
Sir, good evening, sir.
Good
Thank
evening.
you.
Good evening.
Sorry, apologies for the confusion, not sending
No.
the
I
link.
got it. Sorry.
Yes, sir. So we have all the faculty here. Sir, Anurag sir, we have two cases. One is
Right.
Parotid, the other one is Groin Hernia. Which one you want to take it first, sir?
Parotid.
Okay, sir. Okay. So thank you for joining us, sir. Dear
Thank you,
friends, senior faculty, invited faculty, and our regular faculty, residents who are watching us in Zoom as well as in the YouTube. We warmly welcome today's faculty, Professor Anurag Srivastava, sir. He is the head of the Department of General Surgery at All India Institute, New Delhi. Then we have Professor Hitesh Andaria, sir. He is in the Sardar Vallabhai Patel Institute of Medical Sciences, Ahmedabad. And he has kindly contributed to postgraduate Dr. Manek from NHL Medical College, Ahmedabad. And also Rajiv Sinha, sir, is the Professor of Surgery from MLB Medical College, Jhansi, UP. Sir will be joining shortly. His exams are just getting over. He will be joining us shortly. And we have the honor of having all the other senior faculty with us. Rajiv Sakhai, sir, is with us. I could see Professor T. Srinivasan, sir, is with us. And the other faculty and other senior faculty members. Thank you for joining us. Today we have two important cases. Parotid case is to be done by Dr. Prabhu. He is kindly contributed by Professor Srinivasan, sir, from Coimbatore Medical College. And the groin hernia case, Manek, is contributed by Professor Hitesh Andaria, sir, from Ahmedabad. So thank you very much, faculty, for joining us. So we have 1 hour for each case discussion. So initial half can be on the clinical discussion. We can also touch upon management and complications and a little bit on recent advances. Can I request Dr. Prabhu to start your presentation?
Yes, sir.
Thank you. Just a correction. I actually retired from AIMS. So Dr. Sunil Chumbar is the current head, but I retired from AIMS. I served in AIMS till December 2020. Yeah. Thank you.
Yes.
Thanks for the invitation. Yeah. Okay.
Thanks, sir.
Please start.
Prabhu?
Yes, sir.
I would request all the non-faculty members and PGs to mute yourself. If you need to ask, take the faculty's permission in the chat box and then ask. Please mute yourself. Prabhu, you can start now. Good luck to you.
Yes. Good evening, all. I am Dr. Prabhu from Coimbatore Medical College. I am going to present the case of parotid tumor. I would like to thank my HOD, Dr. Lakshmi Narayani, and I would like to thank my chief and guide, Dr. Professor T. Srinivasan, sir, and I'd like to thank my assistants, Dr. Jayalakshmi Ma'am, Dr. Vijay Shankar, sir, and Dr. Balasubramani, sir. 78-year female, farmer by occupation, from Erode, came with chief complaints of swelling in the right side of the cheek for past 3 years. History of presenting illness. Patient was asymptomatic 3 years before. Then she noticed a swelling in the right side parotid region. Insidious in onset, gradually progressive in nature. It was rapidly progressed for past 3 months. There is no history of pain. There is no history of fever. There is history of deviation of mouth to the left side and drooling of saliva from the angle of mouth for past 3 months. And history of inability to close the right eye for past 3 months. And history of facial asymmetry for past 3 months. The history of swelling in the right side of the neck submandibular region for past 2 months. Initially, it was small in size, gradually progressed to present size 3 into 3 centimeter. There is no history of loss of weight, loss of appetite. There is no history of dry eyes and joint pain. There is no history of breathlessness. There is no history of difficulty in opening mouth. Past history, she was known case of Kigu's history of parotid swelling 8 years back. She was diagnosed as pleomorphic adenoma 8 years back, and she was operated superficial parotidectomy done 6 years back, and intraoperative and post-operative period uneventful. Comorbid illness, there is no history of diabetes mellitus, systemic hypertension, cardiovascular disorder, tuberculosis, cerebrovascular disorder, epilepsy, thyroid disorder. Family history, there is no significant family history. Personal history, she consumes mixed diet. There is no history of smoking, alcohol, tobacco nut user, and bowel and bladder abscess was normal. Menstrual history,
Prabhu, you're muted. Prabhu, you're muted. Dr. Prabhu,
unmute. Everybody unmute who are faculties. Otherwise, the noise will come.
Menstrual and obstetric history. P2, L2, both full-term normal vaginal delivery, antenatal, natal, postnatal period uneventful, attained menopause 25 years back, post-menopausal period uneventful. Treatment history, there is no history of chronic drug intake or native medication intake, and there is no history of drug allergy. Summary, 78-year female, history of pleomorphic adenoma, diagnosed 6 years back and operated 6 years back, superficial parotidectomy done, and swelling in the same region for past 3 years, rapidly progressing for past 3 months, associated with facial nerve palsy, facial nerve weakness for past 3 months, and swelling in the right submandibular region for past 2 months.
Okay, Prabhu.
Yes, sir.
Let's go back to your first slide. Yeah, the next one. Right cheek, you said.
Yes, sir.
Swelling in the right cheek. I think can be more specific as a surgeon. Right. This is in MBBS, you can say right cheek. And so you can say in the right parotid region.
Okay, sir.
Because you're seeing her also that time. Okay.
Yes, yes.
And next slide, please. So other than facial deformity,
Yes, sir.
she's got no other, and a swelling. She's got no other symptoms.
No, sir. Swelling in the neck region, sir, submandibular region also, sir.
Okay. So she's got a swelling in the
Parotid region.
So she's got 2 swellings.
Yes, sir. One in parotid region and one in the submandibular region, sir.
Okay. So other than facial nerve involving the lip,
Yes.
there is no other facial nerve involvement. Have you ruled that out by your history?
Sir, patient itself says a facial asymmetry in the right side only, sir, and inability to close the eyes, sir.
Okay, you've done that,
eye signs,
right.
yes, sir.
Okay. Next slide, please. Past history. Okay, she underwent did you find out about the histopath report for the first surgery?
Yes, sir. She has a surgery record, sir. They done right superficial parotidectomy.
Okay.
The report come to be a pleomorphic adenoma, sir.
Okay, next slide. About comorbidities, just let's go to the next slide. I mean, why do you take history of cerebral vascular disorder in comorbid conditions? I mean, usually morbidity conditions we take of is chronically known common diseases, isn't it?
Yes, sir.
Epilepsy and thyroid disorder. I mean, you can ask her whether she's taking any anti-thyroid drugs in drug history or any thyroxine supplement. But thyroid disorder, and that way you can go on and on for any most comorbidities, isn't it?
Yes, sir.
The point is, whatever you mention, Prabhu,
Yes,
the
sir.
questions from examiner's part will come from your statements only. So
Okay.
as far as possible, mention the things which are relevant. So
Okay, sir.
no history of any drug that will be sufficient for even epilepsy and thyroid disorder. Even
Okay,
for cerebrovascular disorder, usually diabetes, hypertension, this is enough. Tuberculosis also is in past history. It is not a comorbid condition, right?
Okay, sir. Yes,
So
sir.
this is what you should take it. Otherwise, you have taken nice history. But the question will arise from your statements only, particularly on online, where we can read again. We can ask you to go back to previous slides.
Okay,
If you are just narrating, you can slip off fast. But this is what you can take care. Very nicely taken history. Next.
Next slide. Okay, no, just
even obstetric
Prabhu,
history you
another
may
thing.
not take in detail in this case. It is not necessary.
Prabhu, in most cases of malignancy,
Yes, sir.
because you think we are sure this is a malignant condition,
Yes,
you
sir.
should take social history, because malignancy involves a lot of money, social support, family support, right? She's
Yes, sir.
78
Okay,
years old.
Yes, sir.
She may undergo surgery, radiotherapy.
Yes, sir.
It's all cost money. So I would always like you to tell me the social history in case
Yes,
of
sir.
malignancy at least.
Okay, sir. I will correct, sir.
No, from this condition, what do you think, Prabhu, it is? Is a recurrent. So what could be a possible, you put a summary as a possible diagnosis, could be a recurrent?
Recurrent swelling from the parotid, probably malignancy.
Probably malignancy.
Yes, sir.
Right. Sir, Anurag,
Can
sir,
you be
please.
more specific? Because you know the histology of the previous operation. It was
Yes, sir.
pleomorphic adenoma.
Yes,
So
sir.
malignancy arising from pleomorphic adenoma. What is the name given to that?
Carcinoma X pleomorphic adenoma.
Okay, so you can be more specific because you know the histology of the previous operation.
Yes, sir. Yes, sir.
Okay, and you said recently for last 2 months or so, she has developed a submandibular region swelling as well.
Yes, sir.
So what could that be? A lymph node?
Sir, yes, sir. It could be probably lymph node.
Based on history, at least a lymph node.
Yes, lymph node, sir.
So it has probably metastasized to submandibular lymph nodes.
Lymph node, yes.
You can go on to the examination now, please.
Yes, sir.
Thank you.
General examination: patient conscious, oriented, and cooperative. Patient well built and moderately nourished. ECG score of 1. There is no pallor, no icterus, no cyanosis, no clubbing, no bilateral pitting pedal edema. The vitals: blood pressure 110/70 in upper arm in sitting position. Pulse rate was 76 per minute in right radial artery. Normal volume and regular rhythm. Temperature was normal. It's a clinical picture of the patient. Local examination of right parotid region. The inspection: swelling of size 8 into 5 into 4 centimeter in the right parotid region, behind and in front of right earlobe, with upward rise of earlobe and obliteration of retromandibular groove, extending superiorly up to zygomatic arch, 6 centimeter from the angle of mouth, below up to angle of mandible, and posteriorly up to mastoid process. Margins are well defined and irregular margin. Surface appear nodular and skin appears stretched, shiny, and erythematous. Multiple dilated vessel present over the swelling. Inspection of the left parotid region normal. On palpation, swelling was not warm, not tender. A swelling of size 8 into 5 into 4 centimeter in the right parotid region. Surface was nodular and odd in consistency. Skin over the swelling was not pinchable, and swelling fixed, not mobile in both vertical and horizontal direction. And examination of oral cavity: there is grade 1 trismus present. There is no displacement of tonsillar pinna or no bulge in the tonsillar fossa, and deep lobe was not palpable. Parotid duct opening was normal, and bidigital palpation of parotid duct was normal. And examination of facial now, and there is a loss of forehead winkling in the forehead winkles in right side of while asking to raise the eyebrow, and difficulty in closing the eyes. In the obliteration of right nasolabial fold, and a deviation of mouth towards the left side while clenching the teeth. This is swellings in the neck region. Examination of neck: there is a swelling of size 3 into 3 centimeter in the right submandibular region, mobile, non-tender, and firm in consistency. There is another swelling of size 1 into 1 centimeter in the upper jugular region, mobile, non-tender, and firm in consistency. Other system examination: cardiovascular system S1, S2 here. There is no murmur. Respiratory system: normal vesicular birth sound present over the lung area and no added sounds. Abdominal examination: soft, non-tender. There is no organomegaly and bowel sound was present. Summary: 78-year female, known case of pleomorphic adenoma 6 years back, operated with swelling in the same region for past 3 years and rehabilitative progressing in nature for past 3 months, associated with facial nerve weakness for past 3 months. And there is swelling of an examination in swelling of size 8 into 5 into 4 centimeter with nodular surface fixed and skin over the swelling not pinchable, multiple dilated vessels over the swelling with facial nerve palsy with enlarged unilateral cervical lymphadenopathy. My probable diagnosis was a case of right recurrent parotid swelling, probably malignant carcinoma, X-pleomorphic adenoma with clinical staging of T4A, N2, N2B and MX disease, stage 4B.
Okay.
So the picture.
Prabhu, can you explain why the earlobe is elevated in patients who have some parotid swelling? It doesn't happen in all, but in many patients who have parotid gland enlargement, there is elevation of the earlobe. It gets lifted up and out.
Yes, sir.
So why does this happen? Earlobe is lifted up and out.
Superficial lobe of
That's a
parotid.
pathognomonic sign of parotid swelling.
Yes, sir.
So what is the underlying anatomy, surgical anatomy? Explain it by basic knowledge of anatomy.
Sir, superficial layer, superficial parotid was present just underneath the earlobe, sir. If it got enlarged, it will push the earlobe upwards, sir.
You mean to say parotid gland is touching the earlobe? Just see your earlobe. You can feel your own ear. I can touch my ear. It is not touching the. It is not touching the parotid at all.
Deep cervical fascia, enlargement of the deep cervical fascia, touching after that.
Okay. So if you recall the anatomy of the cartilage of the pinna, right? Pinna.
Okay. Okay, sir.
And the cartilage of the external auditory meatus. You know, the extra-auditory canal is 2/3 cartilage and 1/3 bony. Okay.
Yes, sir. Yes,
bony is inside and cartilage is outside, right?
Yes, sir. Yes, sir.
Right. The tragus is part of the ear canal, right?
Yes,
so
sir.
the pinna, cartilage of the pinna and cartilage of the ear canal is one piece. It's like a T piece. Let me just show you. Yeah, okay. So if this is pinna, pinna, and this is the ear canal, okay? Can you see it? Okay, this is the ear canal, right? Cartilage is sports, and this is the pinna. Okay, so they are one piece, single piece of cartilage. Go back and read the Gray's Anatomy this evening.
Okay,
and part of the parotid gland goes below, and then behind the cartilaginous portion of the ear canal, auditory canal. Okay, it doesn't touch the pinna.
Okay, sir.
So because the ear canal is attached to pinna, whenever there is enlargement of this portion of the parotid gland, which is called glenoid portion, it is called glenoid portion of the parotid, which lies below the ear canal. When this portion gets enlarged, it lifts the ear canal. You know, ear canal is attached to the bony canal, right? So it gets lifted like this. And pinna is attached like a T piece, right? Like this. So the whole cartilage of the pinna is lifted up. Lobule being lower part, it goes up and out. So this will happen only when glenoid portion of the parotid gland is enlarged, part of the gland lying below and behind the cartilaginous portion of the ear canal. Okay.
Okay, sir.
Now I surmise that in the previous operation, they had removed this part of the gland. So I wonder why the ear canal is still elevated. That means part of this glenoid portion was left. Because usually in parotidectomy, we remove superficial lobe.
Yes, sir.
Superficial to the fasciovenous plane of patent. Yeah. Anyway, go ahead. Sir, other examiners can ask any other questions, please.
Yes. What was your stage, clinical?
Sir, clinical stage T4A and N2B, sir.
So one point I like to highlight is mention M0 as far as there is no metastasis clinically.
Okay, sir.
Right? Because this is a clinical staging. So either it is M0 or M1. This was discussed in last NSCP also in Principles of Oncology by Dr. Madhu sir. So if clinically there are no evidence of metastasis, always mention M0. If there are evidence, if pathologically or on investigation, it may turn out anything. So it is either M0 or M1. Right? There is, you should not mention MX for all malignancies.
Okay, sir.
Okay. Prabhu, now how will you proceed in this patient?
Sir, I would like to confirm my diagnosis with the tissue.
Okay. Hang on. Let's go back to your examination.
Yes, sir.
Forward. Yes, let's go back to examination.
You go for a clinical examination. Raju sir has got. Raju usually says, "Good evening, Raju sir."
Okay, good evening, sir. Okay.
When the deep lobe is not seen or protrusion, you cannot tell about palpation.
Okay, sir.
And you cannot palpate the deep lobe just like that.
Okay.
You say there is no fullness in the tonsillar fossa.
Yes, sir.
Then why do you want to say palpation of the deep lobe is not done? That is not correct. I told you to correct it. No problem.
Okay. So let's go back to your first slide of examination, local regional examination. So it's a large swelling, which is of the parotid, right?
Yes. Yes.
Now, okay, the next slide, please. What do you mean by grade 1 trismus? What are the grades of trismus?
There's 4 grades of trismus, sir. When we insinuate 4 fingers inside, intra-incisor distance between if we can insinuate 4 fingers, it means grade. There is no trismus, sir. If we insinuate,
how much centimeters would that be?
Sir, more than 10 centimeters.
10 centimeters. Sorry, it's 3.5. Prabhu, it's 3.5. 10 centimeters is very large. You can't open it. It's not a crocodile's mouth here.
Sorry.
So whose fingers, Prabhu? Your finger, patient's finger. So I said the centimeters is correct.
Okay, sir.
3.5, greater than 3.5?
4 centimeters.
Yeah.
Yes, sir.
Prabhu, with a 10 centimeter mouth opening, you can eat the whole Tirupati laddu directly in one piece.
Sorry, sir.
Okay. Okay. And no displacement tonsillar pillar, bulging tonsillar fossa deep, not palpable. Okay, yes, like sir said, it's not, you don't write it as palpable.
Yes,
it's
sir.
Just a inspectory finding.
Okay, sir.
How could you do? Could you do a bidigital palpation in this patient? Of any other way of examining the parotid duct? What are the 2 ways of examining the parotid duct? One, you do a bidigital,
yes,
right?
Sir. Yes, sir.
And the other way, you clench the teeth and you try to roll the
finger
over the masseters.
Yes, sir.
Okay. Next slide, please. Okay, loss of forehead wrinkle on the right side. How will you distinguish between upper motor neuron and lower motor neuron affection of the facial nerve?
Both upper and lower faces involved, it infers as lower motor neuron is affected, sir. If only lower face of the upper portion is bad and lower portion of face is involved, it is upper motor neuron lesion, sir.
So what is the peculiarity about this upper motor neuron?
There is a sparing of upper side of the face, sir.
Right, it's got a bilateral
bilateral innervation
of the forehead. Okay.
Yes, sir.
That's right. Okay. It's on the right side. So why is the mouth deviated on the left side?
Sir, on clenching the teeth, only patient has normal side muscle is working, sir. Abnormal side, affected side muscles are not working, so mouth is deviated towards the opposite side, sir.
Okay. So difficulty in closing right eye. Did you examine the conjunctiva and the sclera of the?
Yes, sir. There is no conjunctivitis. There is no carotid.
So there is no desiccation or ulcer, or
yes,
is the eyesight normal from the right eye?
Yes, sir. There is no conjunctivitis. There is no carotid.
I think I would like you to mention this.
Okay,
because
sir,
she must be having this for 3 months.
Okay,
you must mention specifically that the conjunctiva and the sclera and all are normal. Okay.
Yes, sir. Okay.
Okay. Next slide, please.
So Prabhu, you should say that
yes,
due to unopposed action of the normal side of the face,
okay,
the angle of the mouth is pulled towards the normal side. That is opposite to the paralyzed side. Unopposed action of the,
Yes,
right?
Is that the right word? Unopposed.
Yeah,
Yes, sir.
unopposed.
Okay, sir.
Right. Next slide, please. Okay. Okay, next slide. Is motility of the mobile? Okay, it's mobile.
Yes, sir.
What is the significance of motility of the lymph node?
If it is mobile, it may be probably a benign condition or malignant condition, sir. But if it is mobile, it is there is no extranodal extension is present. If it is fixed to
right. Usually when it is fixed, surgery
yes,
becomes very difficult.
Yes, sir.
You have to go in for a conjunct radiotherapy or something, right?
Okay, sir.
Okay. Right, sir. Please take over.
Go ahead with investigations. Your provisional diagnosis is based on history and examination.
Yes,
Lady aged 78. You should not say female, right?
Yes, sir.
Give more respect. Say lady.
Okay.
No,
Okay.
lady, or for male, it's say gentleman. Don't say female, right? We
Okay.
usually use female and male for animals. So when we describe an animal study, we say that we took 20 female Western rats. For human being, be more respectful. Say lady aged 78, postmenopausal 20 years ago, had a surgery for parotid gland. A pleomorphic adenoma was removed, and now she has come back with a recurrence of the swelling in the same region with the lymph node enlargement, perhaps pleomorphic adenoma, carcinoma at pleomorphic adenoma, right? And with facial palsy, And fixity of the fixed lymph node. Was it lymph node fixed?
No, sir. Mobile
lymph node.
Yes, sir.
But the swelling mobile on the face, or it is fixed to masseter or fixed to mandible?
Sir, it's fixed to masseter. The swelling is not mobile in both the directions, sir, and vertical and horizontal directions. It's fixed to.
So when masseter is relaxed, unclenched teeth, then you can move it slightly, and yeah. Or it is fixed to mandible?
No, sir. Only fixed to masseters. On clenching, it is not fully mobile on clenching the teeth. Sir.
Otherwise, you can move a little bit.
Yes, sir.
Otherwise, there is some.
What is the significance of this? What is the significance of this? Attachment to the mandible, attachment to the masseter. Is there any significance to it?
It will depend on the invasion. It will depend on the staging, sir. If it is invest to the masseter alone, it will come under stage 4A, sir. If it is close to mandible, it will come under stage 4B.
So, as a surgeon, how are you affected by that?
Sir, we need to remove mandible. We need to operate mandibulectomy if bone is involved, sir.
And what about radiotherapy?
Yes, if it is 4B, we have to give there is first line. We have to go for palliative chemotherapy, radiotherapy, sir.
No, can you give radiotherapy when it's fixed to the bone?
No, sir.
After removing the involved bone. So,
yes, sir.
Let us discuss the plan of investigations.
Then we'll
first tell
specific
investigations aimed at ascertaining the diagnosis.
Yes,
and then secondly, we will ask other investigations, right?
Yes, sir.
Right. So, like
specific investigations aimed at
you should write,
the diagnosis.
Like Professor Anurag said, your diagnosis should include involvement of the facial nerve and the level of lymph node.
Okay, sir.
Right? It should.
Okay.
So, investigations, how will you proceed?
I would like to confirm my diagnosis with the FNAC, sir. FNAC of the swelling.
No, before that, imaging. Have you heard the word triple assessment? We use it in breast, but the same principle applies anywhere else in the body. Clinical assessment, followed by imaging of the organ, followed by histology or cytology. Okay?
Yes,
you should not break that cycle. The sequence must be followed. Otherwise, if you put a needle, suppose there is a cyst, and cyst will disappear. And then the radiologist will say, oh, I can't see anything, right?
Yes, sir.
So if it's a very vascular malformation, for example, hemangioma or vascular malformation or a vascular tumor, and you put a needle, you will cause sudden hemorrhage. And there are some lesions in the neck area, head and neck area, where you are not allowed to put a needle. Can you name any lesion?
Sir, hemangioma.
Hemangioma and carotid body tumor.
Yes, sir.
Carotid body tumor, right? It is so vascular, so profusely vascular that if you put a needle, you will cause immense hemangioma. So paraganglioma and hemangioma and carotid body tumors are some of the very vascular lesions where we should not be putting needle. So how will you know that? Only by appropriate imaging. So clinical assessment followed by imaging, followed by biopsy or cytology. Okay.
Yes, sir.
So the triple assessment. This is called triple assessment.
Yes, sir.
So follow triple assessment. Yes, please. So what megahertz or frequency probe, ultrasound probe will you be using? Now we say that ultrasound is the surgeon's stethoscope. It's extension of palpation. So you must know, surgeon should do and learn his own ultrasound. So what frequency probe will you be using?
So 3.5 to 5 megahertz.
No, 3.5 to 5 is for deep structures like kidney, renal vessels, liver. For superficial structures, 7.5 to 13 megahertz probe, right? So more superficial the structure, higher is the frequency, right? Because penetration is reverse of the frequency. It depends on wavelength. So for parotid or for breast, we use 7.5 to 13 megahertz probe. Okay. High frequency probe, high resolution, high frequency probe. And will you be using only 2D ultrasound or something more information you can gather from ultrasound? You can have the blood flow information, right? So these days, most modern ultrasound machines are fitted with duplex ultrasound. Duplex means 2D imaging plus the vascular blood vessels information. So you can see a vessel, pulsating vessel, put the color code. You can see red or blue vessels, artery or vein. Then you put a cursor inside that pumping vessel, pulsating vessel, and you can know the blood flow. The blood flow in malignancy is profoundly increased because of tumor-induced angiogenesis, right? So you can assess the blood flow. So you should be doing that because that may tell you about the feeder vessels, where the main vessels are coming. And if you are planning a biopsy or a needle aspiration, then you should divert the needle away from those vessels. Otherwise, you will cause profuse hemorrhage and hematoma formation. Okay. And so she is 78, elderly lady, right? And doctors often put these elderly persons on some medicines. If they have hypertension or diabetes and hypertension, they put on the aspirin or ecoaspirin, isn't it? Right? Physicians often do that. Will you be stopping the aspirin a few days prior to putting a needle or not?
We will stop the antiplatelet drug 3 to 5 days before any procedure.
Right. Okay. So go ahead. So you have done high resolution ultrasound of the swelling and of the neck. Neck ultrasound is very important for identifying the suspicious lymph nodes, right? For thyroid, for parotid, for all head and neck cancers. Now, high resolution ultrasound of the neck for ascertaining the lymph node involvement is very important, right? And you can do aspiration cytology from the. So in parotid, we are happy with cytology, fine needle aspiration cytology, FNAC. What size needle do you use for FNAC in parotid? Needle, which color?
The 25 gauge needle, sir.
25. 25 is very thin. 23. You can remember by color of your shirt, blue color, blue, right? Your shirt is blue, so blue color, blue needle is 23. So most FNAC for thyroid and parotid are done with 23 gauge needle, because if you put a very thick needle, you will cause more hemorrhage and damage. And here we are worried about damaging the facial nerve. Even if some sub branches are paralyzed, we don't want to damage the unparalyzed branches, right? And if you put a thick needle, at least in parotid swellings, they say that there can be seedling along the needle track. So needle track seedling and recurrence can occur if you are taking a thick needle aspiration or a biopsy using more than 23 gauge needle, right? If it is a pleomorphic adenoma, which is notorious for recurrences, as it happened in this lady.
Yes.
Okay. So,
can you describe the sonography ultrasound findings of lymph nodes in general for considering it normal or diseased? General principles.
Shape of the swelling, sir.
Yes.
And the margins of the
what is the normal shape of lymph node?
Tell it, Steven. Professor is asking from what, when it becomes malignant, what will be the shape?
Normally, it is a kidney bean shape swelling, sir. If it is malignant,
what is the axis? Usually, it is
long and vertical, taller. And if it is more broader, it is probably a malignant.
The round ones are pathognomic. Yes.
Yes, sir. And
anything else? Smooth periphery. Any breach in periphery?
Capsular breach is there. It is more towards malignant, sir.
Fatty hilum is normal, whether it is preserved or not.
Yes,
these
sir.
all things.
Okay.
Loss of fatty hilum. You must say loss of fatty hilum.
Yes.
Okay.
That's an early sign of a lymph node, suspicious lymph node on ultrasound, right?
Yes, sir.
So loss of fatty hilum, architecture distortion, the length to breadth ratio, the change in shape from rainiform or kidney bean shape to rounded, right? And irregular margin. And if you have put the Doppler probe on that cursor, Doppler vascular cursor, you can see increased vascularity.
Okay.
So increased vascularity is a feature of malignancy, right?
Okay. Yes,
so all these parameters should be seen, and echogenicity within the cortex, right? So these are nicely described by Professor Mansell in British Journal of Surgery. So please note down the reference. It is British Journal of Surgery, Barua, Goyal and Mansell, May 2010, page number 680. Sonographic features of suspicious lymph nodes.
Okay.
British Journal of Surgery, May 2010, page number 680. Very nicely described.
Okay.
Thank you. You can go ahead now.
Prabhu, like so said, the blood flow in malignancy is increased. This is known as restive index. In Doppler, we call it restive index, in which we anything more than 0.75% is taken as malignant.
Okay.
Yeah, please. Okay, so now what will you do now?
What is the investigation you have done, Prabhu?
After ultrasonogram, I would like to do FNAC of the swelling, sir, to confirm the diagnosis and FNAC of the swelling in the neck also, and the lymph node, sir, whether it malignant or it is benign node.
Okay, so you've done do you want to do a true cut core biopsy or do you want to do an FNAC?
Sir, FNAC of the swelling, sir.
Okay, why do you want to do an FNAC or a core biopsy?
Sir, in parotid, if it is core biopsy, it will lead to seedling of the tumor, and there is a chance of facial nerve injury.
Okay, Prabhu, but here in your case, the facial is already involved. The skin is also involved.
Yes, sir.
Right?
Yes, sir.
So usually in such cases, you can go in for a core biopsy or even an incisional biopsy here, a punch biopsy, right? An ultrasound guided punch biopsy is also. But in for secondaries, of course, an FNAC. Okay, so what have you got the reports?
Yes, sir.
Let's have the report.
Sir,
have you got the ultrasound done?
Yes, sir. Ultrasound is
ultrasound report.
Sir, ultrasound report is showing there is a 9 into 5 into 4 centimeter swelling in the parotid region, hypoechoic lesion in the right parotid region with increased vascularity, sir. And there is a swelling in the right submandibular region, 3.5 into 3 centimeter in the submandibular region, single swelling with increased vascularity and the loss of fatty hilum of the lymph node, and there is a decreased architecture, probably metastasis.
Okay, Prabhu,
Yes, sir.
in ultrasound, what are you interested here really in? Are you interested in knowing whether the lump is from the deep lobe or the superficial lobe? Because you've
Yes,
done
sir.
a superficial paratectomy. How will
Yes,
you know
sir.
that this is from the deep lobe?
Sir, yeah.
So, Prabhu, you got the ultrasound report, which
Yes,
is
sir.
suspicious, which is raising the suspicion of a malignancy.
Yes, sir.
So, before putting the needle, you
Yes,
should
sir.
be doing one more imaging. What is that? Contrast enhanced CT scan, contrast
Okay.
enhanced CT scan,
See,
or
sir.
contrast MRI, right? One of these two.
Okay.
Why? Because we want to assess the deep lobe exactly, right? Number
Yes,
two,
sir.
we want to assess all the lymph nodes.
Yes, sir.
And number three, we want to assess its extension into
Yes, sir.
parapharyngeal space,
Yes, sir.
right?
Yes, sir.
Where the deep lobe lies.
Yes, sir.
So, in any patient who has suspected deep lobe enlargement, recurrent tumor, and malignant, there are three indications: recurrent, malignant, and deep lobe,
Yes, sir.
based on clinical features. You
Yes,
must
sir.
get contrast CT or contrast MRI, because
Yes,
you
sir.
want to know whether how much of deep lobe is enlarged, it is
Yes, sir.
extending into parapharyngeal space, infratemporal foci space, and
Okay.
whether it is involving some very vital blood vessel, like which blood
Carotid,
vessel
sir.
you worried?
Carotid
Deep to
artery. Sir, carotid artery, sir.
which carotid? There's no artery in human body called carotid.
Sir.
We have common carotid, we have internal carotid, we have external carotid. So it is internal.
External. Yes, sir.
Internal.
Internal
External, so we
carotid.
always tie, no? We can tie.
Yes, sir. Yes,
In fact,
sir.
the patient, your teacher, your professor will be tying because it is tumor is going there, you know. So external, near the lower pole, you will be tying. But the internal, you have to
Yes, sir.
preserve the internal, right?
Okay.
Because it's going to the brain.
Yes, sir.
You must also assess if internal carotid is involved. What is next assessment? Assessment of circle of Willis patency. Because
Okay,
if you happen to catch or clamp the internal carotid artery due to bleeding,
yes,
then circle of Willis is not patent. You will cause infarction of the half of the brain,
yes,
hemiplegia, a stroke on table can happen. So you
Okay.
must assess the internal carotid artery carefully by
sir.
and that then only by contrast CT scan or contrast.
Okay, MRI. MRI. Sir.
In the form you should be writing,
Okay, sir.
please contrast CT scan to focus on infratemporal fossa. Infratemporal fossa and parotid region, of course, they will do, but you
Okay,
must
sir.
please focus on infratemporal fossa.
Yes, sir.
Prabhu, one technical question. As the talk of external carotid ligation came, suppose in emergency you are supposed to ligate external carotid artery in neck. How will you confirm that this is not internal artery, internal carotid artery? Is there any way? So the position keeps on changing, and it is patient is somewhere bleeding in tonsillar fossa or whatever.
Okay.
So how will you confirm that this is the external carotid artery and not internal carotid artery before ligation?
The external carotid artery is having branches in the neck, sir. There is internal carotid.
Internal is not. Yes. Okay. Very good.
Prabhu, you've done the ultrasound.
Yes, sir.
Did the ultrasound tell you anything about the deep lobe?
Sir, deep lobe is free from the disease, sir. It told.
Did they say that deep lobe is involved or not?
Not involved, sir.
Okay. Still, if the ultrasound says so, you'll have to, like sir said, you'll have to go in for CCT, right?
CCT, yes, sir.
Right.
Yes, sir.
In the head neck.
Okay.
Okay. And you've done your biopsy, and what has the biopsy shown?
Sir, it's in FNAC of the neck, it shows a metastatic deposit, sir. And FNAC of the parotid swelling, it shows
Just shows the report if you have one.
I don't have, sir. And I not included, sir.
So if you don't have the report, but you know the history, previous
Yes,
operation was for pleomorphic adenoma, and now there is a recurrence. So
Yes,
if you don't have the report, just guess what pathologist would describe. Recurrence, you said carcinoma at parotid, at
Yes.
pleomorphic. So
Yes, sir.
what will be the histology type? In other words, we want to know what are the various malignancies of the parotid gland that you know.
Adenomas, lymphomas, carcinomas. Sir. The low-grade lesions are acinar cell carcinoma, adenoid carcinoma, and
tell the more common. Mucoepidermoid.
Yes, sir.
Mucoepidermoid is far more common than
Yes,
acinic
sir.
cell. Acinic cell,
Yes, sir.
etc. Very rare case reports.
Okay, sir.
Right?
Yes, sir.
Mucoepidermoid, low grade and high grade. And then adenocarcinoma.
Carcinoma. Yes, sir.
So what type of carcinoma will it be if it is in a recurrent pleomorphic adenoma?
Probably yes, sir. Mucoepidermal carcinoma.
Mucoepidermoid is a disease de novo. It is not following previous pleomorphic adenoma. Did you read it somewhere? That pleomorphic adenoma converts into mucoepidermoid? I have not read it.
Okay.
I thought mucoepidermoid is a carcinoma, malignancy de novo.
Okay, sir.
Yeah. So it's a adenocarcinoma. And what are the elements in a pleomorphic adenoma? Pleomorphic. Why do we use the word pleomorphic?
Sir, both.
Not monomorphic. Monomorphic is a separate disease, right? Pleomorphic.
Sir,
so what are the elements, histological elements?
Epithelial cells and mesenchymal cells, sir.
Mesenchymal. So in the mesenchymal, what all components do you get?
Sir, cartilaginous compounds.
Cartilaginous portion and fibrous tissue and even so mesenchymal, and so it's a mixed neoplasm.
Yes, sir.
Can you name any mixed neoplasm in breast? Mixed neoplasm in breast. Phylloids tumor with the same P. So you can remember P, letter P.
Okay.
Pleomorphic adenoma and phylloids, or mixed neo lesions.
Okay.
Okay. So now you tell the investigations to assess the operative fitness, anesthetic and operative fitness, and stage the disease. So far, we have done the investigations aimed at ascertaining the diagnosis. Okay.
Yes, sir.
So diagnosis is recurrent malignant pleomorphic tumor involving the facial nerve, involving the lymph nodes in the neck, the medulla.
Yes, sir. Yes, sir.
And they suppose we have done the contrast enhanced CT, and the deep lobe is enlarged because superficial lobe has already been removed, and but the parapharyngeal space is normal, internal carotid artery is normal.
Yes,
how will you proceed? And circle of Willis is patent. No history of stroke in the past.
I will counsel the patient for surgery, sir. And
you will assess the operative and anesthetic fitness, isn't it?
Yes, sir. Yes, sir.
Suppose she has orthopnea, she has severe cardiac failure.
Yes, sir.
Right? She's 78. You know, at this 78, people are allowed to have other comorbidities.
Okay, sir.
So you'll assess the operative and aesthetic fitness.
Yes, sir. I will do investigation like complete hemogram and renal function test, ECG, echo, and chest X-ray, sir, for anesthetic fitness.
An evaluation by a senior anesthetist, because there may be problem in intubation.
Yes,
with
sir.
a large swelling which is fixed in the region. It may be difficult to have wide opening, and intubation may be a problem.
Okay.
So a senior anesthetist must assess the ability to intubation, endotracheal intubation.
Okay.
Because they may have to resort to some, either these days they have video assisted, intubation or nasal intubation, or they may even need, if all these fail, then may have to do tracheostomy on table.
Okay.
So you should be prepared with all these, right?
Yes, sir.
With a large head and neck tumor.
Yes, sir.
Right. What kind of surgery will it be called? Name of the surgery. She already had superficial parotidectomy.
Yes, sir.
So what did we call it?
Radical parotidectomy.
Radical. So
Yes,
how do you define radical parotidectomy, please?
The removal of both the superficial and deep loop along with the facial nerve and along with the deep structures like masseter muscle and underlying tissues, sir.
Yeah, some people like Dr. Jatin Shah, who is the world authority in parotid tumor, head and neck neoplasm from Memorial Sloan Kettering, New York. He says there is nothing radical about parotidectomy. So even if the report is cancer, but it is not fixed, as in this case, but in an early case, even if report is carcinoma, they say we do not remove the overlying skin. We do not remove the underlying muscle or the ramus of the mandible unless they are fixed. Unless they are fixed. That's advanced, right?
Yes, sir.
So he says and we do not remove uninvolved branches of facial nerve. If a branch is already involved, so that's why pre-op assessment of each branch of the facial nerve is very important. In description of the case, you should say, I have examined all the branches and all the branches of facial nerve are intact. That should be your description. So if the branch is not involved pre-operatively, then in early case, you have no right to remove uninvolved branch of the facial nerve. So he says there is nothing radical about parotidectomy, cancer. Even in cancer, we preserve the facial nerve. If it is not involved, we preserve the overlying skin. If it is not involved, we preserve the underlying ramus of the mandible if it's not involved, right? So the term is radical, just encompasses removal of the entire parotid with its capsule intact. You should not be spilling the tumor in the field, otherwise you will get recurrence. And preserve, dissect, and then preserve all the branches of facial nerve.
Okay, sir.
Now, can we ask you, points about how do you identify the facial nerve? There are two approaches how to dissect the facial nerve: retrograde and trunk first and branches first. So, do you know something about them? Have you assisted any parotidectomy surgery?
Yes, sir.
Okay, so tell about the trunk first. Most surgeons use trunk first.
Yes,
so
sir.
Yeah.
Now is just about to the digastric muscle, sir. Digastric muscle incision are just
posterior belly of digastric.
Posterior incision of posterior belly of digastric muscle, and
you can remember like the landmark, most constant landmark. Dr. Jatin Shah says it's almost always there. There is a branch of stylomastoid artery. It's called sentinel artery of Jatin Shah. Sentinel artery of Jatin Shah. Like no sentinel lymph nodes in the neck, sentinel lymph node in breast, So there is a sentinel artery of Jatin Shah. It's a branch of stylomastoid artery, and it runs 4 millimeters superficial to the trunk of facial nerve. 4 millimeters superficial and parallel to the facial nerve, right? So you dissect first. You dissect the anterior border of the sternocleidomastoid, tiny tendon of sternocleidomastoid. You retract it backwards, dissect deeply, and then you get the posterior belly of digastric. How do you identify posterior belly of digastric? How do you contrast it from sternomastoid? Sternomastoid is vertical, and this posterior belly digastric is transverse. It's almost at 90 degrees. Okay, so horizontal fibers, and it's which type of muscle?
Unipennate.
No, the fibers go like this,
No.
So digastric, so posterior digastric muscle is identified, and then you trace the upper border of the muscle where the muscle meets the mastoid process and bony meatus. Where the bony meatus, mastoid process, and posterior belly of digastric meet, these three structures meet. That is the point of emergence of facial nerve from the stylomastoid canal. And this is almost constant, where the mastoid process, bony meatus, and posterior belly digastric, these three structures meet. That is the point of emergence. And in almost all cases, you will find the trunk there, unless tumor is very big, filling the retromandibular space, pushing and disturbing the anatomy, Only in those cases, we go for branches first. Now here surgery has been done previously. So this area may be difficult to dissect due to scarring. So you may have to go for branches first. Now when you operate on a case of recurrent parotid or recurrent thyroid also, what special instrument will you request the sister to get? It may not be in general surgery OT. You may have to get it from pediatric surgery. What is that instrument called? Or neurosurgery? Nerve stimulator, right? Always keep a nerve stimulator, and some people will say magnifying either loops or microscope, because the branches may be enmeshed or surrounded by lot of fibrous tissue. And you may have to It may look like fibrous tissue, but when you cut, you find, oh, it was the facial nerve. So distinguish a scar tissue from fibrous tissue, from nerve. You should be using magnification and use nerve stimulator. Two things are mandatory when you're operating on a recurrent tumor or a very large tumor.
One thing I like to add for beginners is when you are doing first few parotidectomies, superficial, of course, they will be de novo, not recurrent. The facial nerve is far deep than what we think. Usually people start worrying as soon as they reach the sternomastoid. But if you follow the landmarks which sir has already told, you have to reach straight away there, and then you think or worry about. Otherwise, it keeps on sweating yourself. And by the time nerve comes, you are tired and it may be damaged or there may be some bleeding. So the landmarks are very nicely has to be remembered and you have to follow it.
Thank you, Dr. Hitesh. Very well said. It is much deeper than what we think, you know,
Yes.
and it
happened with me as a beginner, sir. That's why I always tell this.
It happens with all of us. It happened with me so many times. Yeah. So always keep a senior person around, especially I usually request a professor of ENT because they use microscope. They are expert in not only dissecting, but also anastomosing. Suppose a branch of the nerve has to be sacrificed. So they will either anastomose directly if there is not much gap, or take any nerve that you can take from this area. Can you name some nerves? It's there in the field. Dissected in the flaps. Greater auricular nerve. Greater auricular. So you should not be sacrificing greater auricular. You should keep it because it may be needed for anastomosing a lost segment of the facial nerve. And so they use 8-0 or 9-0 sutures and do not too many sutures, otherwise you cause nerve damage.
Prabhu,
vesicular.
In this case, you have to manage the facial nerve. That is the exposure keratitis or the eye not closing properly and the drooling of the mouth. So you, in this case, you will not use the greater auricular nerve. Why? In cases of malignancy, will you use the greater auricular nerve or will you not use the greater auricular nerve, and why?
Sir, there is in tumor, there is a perineural invasion is there, sir.
Right. So greater auricular nerve has a high chance of involvement in malignancy. So we avoid greater auricular nerve use in reconstruction. We use the sural nerve.
Yes, sir.
Right. And also branches of the facial nerve distal to the canthus, lateral canthus, they regenerate on their own. So we don't do anything about them.
Okay, sir.
It's only the main trunk which we have to. And what is this graft called? The special type of graft used here for facial nerve?
Cable graft, sir.
It's called a cable graft. So what is a cable graft?
Connecting the 3 or 4 fibers of the nerve, sir.
Right. So like in cable, you have a few wires which are twisted.
Yes, sir.
In the same way, we take pieces of nerve and we join them together.
Okay.
Okay.
Yes, sir.
Yes, sir. This case is quite interesting. We discussed it with the tumor board, the oncologist.
Right.
The surgery was a bit exhaustive surgery. So what was planned and what was done, Prabhu, you have to explain to them in detail.
Yes, sir. Sir, we planned for a radical prostatectomy with modified radical neck dissection along with pectoralis major myocutaneous flap cover.
Very good. So since you discussed in the tumor board with the medical oncologist, radiation oncologist around, so was there any suggestion for giving pre-operative neoadjuvant chemotherapy or radiotherapy? Is there any role of neoadjuvant chemotherapy or radiotherapy to shrink the tumor, to make it operable or mobile? Is there any role in the literature? Because in most other tumors, now we are adopting this neoadjuvant approach in breast, certainly always, and in many head and neck neoplasms also. Now they are approaching neoadjuvant chemotherapy or chemo and radiotherapy to shrink the tumor and to make it more mobile and field margins, of dissection sterile. Otherwise, you just spill the tumor cells everywhere, right?
Okay.
I don't know about the role of neoadjuvant therapy in parotid, recurrent parotid, but in other cancer, certainly they have described its benefit.
Okay.
Yeah, Prabhu, why do you think this thing has reoccurred? And what would he have done in the first surgery to prevent this kind of recurrence or malignancy?
Removing the tumor with the capsule, along with the capsule set.
Okay. What else? We have prevented any spillage. One is that. Also, what? If your tumor was of high grade initially, right, then we would have gone in for a radiotherapy in the first instance. You should go in for radiotherapy if the tumor is of high grade, or it is involving the neurovascular bundles. Then it is important to give radiotherapy. Right.
So will you tell about extent of nodal dissection? What kind of dissection, lymph node dissection will you be carrying down for cervical lymph nodes?
So since it is a N2B disease, I would like to go for a modified radical neck dissection. So
what are set of nodes, or levels of nodes will you remove? Mention the levels of the nodes.
So level 1A, 1B, 2, 3, 4, 5, up to 5 group of lymph node along with the lymphoid tissues we will remove modified radical.
So there are some lymph nodes along the accessory nerve. In the posterior triangle, there are some lymph nodes along the accessory nerve, and they are often involved in parotid tumors. So in the posterior triangle, you should be dissecting these nodes, especially nodes along the accessory nerve. And as Dr. Thai was saying, the nodes along the greater auricular nerve, they may engulf that nerve and cause perineural nerve spread. And so which set of nodes are there around the greater auricular nerve? What is the name given to those nodes? They are outside the deep cervical fascia. They are nodes along the external jugular vein. So if you dissect the external jugular vein, external jugular and greater auricular nerve run parallel, right? So there are 3 or 4 lymph nodes along that external jugular vein. Most of the lymph nodes are along the internal jugular, deep to deep cervical fascia, investing lamina. But here few nodes are there along the external jugular, and in these cases, if they are involved, then the external, then the greater auricular nerve may also be involved. Okay. So reconstruction was by pectoralis major myocutaneous flap. What kind of flap it is? Plastic surgeons describe, classification of flaps: type 1, type 2, type 3, type 5. The classification. It's called Mathes and Nahai classification.
Yes, sir. So only one particle is there, sir. Therefore, pectoral myocutaneous.
No. It's called type 5 flap. There are 2 muscles in the front, pectoralis major, and on the back, latissimus dorsi. They are called type 5 flap, where there is one dominant vascular pedicle and other segmental multiple pedicles from the other side. So in the latissimus, thoracodorsal artery, right?
Yes, sir.
Thoracodorsal branch of the subscapular artery is the main feeder. One. On the other side, branches from the lumbar artery, right? From the distal side on the back, branches from the lumbar artery and branches from intercostal arteries. They are also coming from the deep surface. And you can have reverse latissimus dorsi flap, which is often used by plastic surgeons for covering bed sore or spina bifida defect on the back. So there they cut the thoracodorsal pedicle. They will cut the main pedicle in the axilla, and they will take this muscle backwards, downwards, based on those lumbar branches, right? So that is the distal vascular pedicle, and it's called reverse latissimus dorsi, right? So it has dual blood supply. Just as pectoralis major also has dual. Main is the, which is the main artery?
Thoracodorsal.
Pectoralis major. You did pectoralis major.
Yes, sir.
Name the main artery.
Perforating
Pectoral branch of thoracoacromial artery.
Yes, sir.
Pectoral branch of thoracoacromial artery is the main feeder, but
sir.
it also gets distal supply from the same intercostal and the superior epigastric artery, where the rectus sheath pierces. So it again has dual supply.
Okay.
Prabhu, one more important thing.
Yes,
how will you counsel the patient for any parotid surgery, not this in particular, and how will you take consent?
I would like to tell we have to remove all the entire tumor cells and along with the parotid and underlying deep structures. There may be a chance.
Patient will not understand anterior and all this. So what complications you need to explain, and how will you take consent?
I will take consent for facial nerve injuries. There is a.
But so patient will run away. How will you explain this? If you say that this can be damaged,
yes, sir.
no patient will come for surgery, right?
Yes,
so how will you explain the patient?
There is a chance of damaging the nerve. There is a if the nerve is damaged, patient can get weakness of the inability to close the eyes.
So if you explain all drawbacks, yes, no one is going to come to you. So how should you explain? See, you have to explain the percentage wise, or maybe whatever is your record or department's record. This is how you have to explain that it can happen, does not happen. And second thing, even if it is not damaged, there can be transient neuropraxia, which many times happens. So this is all you need to explain. Any other complications you will like to mention in your consent? In other words, what are the complications of superficial parotidectomy?
Wound infection.
These are all common, specific.
It's a recurrence of the tumor, sir.
Okay.
What is Frey's syndrome? Frey's syndrome. Gustatory sweating syndrome.
Yes, sir.
Described first by Emila Frey. Yes, Emila Frey, a lady neurologist from Poland, Warsaw, Poland.
Yes,
she was killed in the German invasion of Poland. So if you read the footnotes, in Hamilton Bailey, you will read about it. Yeah. So what did she describe? Frey's syndrome. Frey, Frey's syndrome.
During superficial parotidectomy, there is a chance of parasympathetic fibers are anastomosed with the auriculotemporal nerve. There is a chance of while eating food or any smelling the taste of food, patient may develop sweating over the parotid region, sir.
Sweating and erythema. So what happens that secretomotor fibers, should say in the exam, secretomotor fibers of the branches of auriculotemporal nerve which supply the parotid, secretomotor fibers get connected to the sympathetic fibers of the skin of the dermis, sweat glands, right? And in sweat, the sympathetic supply of the dermis is secretory for sweat glands and is vasodilatory. So the area of the face becomes red, and due to sweating, it becomes wet. So even the thought of food, food, eating, or thought of food, because thought of food can stimulate the secretion from the glossopharyngeal nerve. Parotid gets supply from glossopharyngeal or from chorda tympani. Secretomotor fibers, glossopharyngeal, ninth nerve, right? You can remember like this: ninth is below, right? And parotid is above. So it's the reverse. For the upper gland, it comes from ninth. The submandibular gland is below, so it gets from above seventh nerve, chorda tympani, secretomotor fibers. Okay. So secretomotor fibers, branches of auriculotemporal, get connected to the sympathetic fibers of the sweat gland of the dermis. And how can you prevent it? As a surgeon, you can prevent it. You can place some tissue in between the skin and the dissecting bed. What can you put? Sternocleidomastoid muscle. Detach it from the mastoid process and mobilize it. Transpose the sternomastoid in the parotid gland bed, dissected bed, and with 2 or 3 interrupted vicryl or monocryl absorbable sutures, just very gently, carefully preserving the branches of facial nerve, you can transpose. So this muscle transposition, sternomastoid transposition, has 2 functions. It prevents the Frey syndrome, and more importantly, it fills the gap Otherwise, there is a depression.
Yes,
You know, patient says, doctor साहब बहुत गड्ढा हो गया, बहुत depression हो गया, especially in young girls. You know, young girls going for marriage, etc. It's very important to fill this gap by transposition of the sternocleidomastoid.
And even if it is not filled for smaller tumors, one has to take care that the superficial flap is not very thin. While dissecting, you should not see any of the hair follicles on the undersurface. That is probably going to take care of this complication. Not always, but this is one tip given.
Right. Thank you. Thank you, sir.
So the photograph.
Just recall the anatomy branches of facial nerve.
There is 5 branches of
6.
Yes, sir.
Usually 6. 3 from upper trunk, 3 from lower trunk.
Sir, in upper
what
trunk,
is the new upper trunk? Upper trunk is called temporofacial.
Temporofacial, yes, sir. Superficial temporal and
no superficial temporal. Temporofacial will give temporal, zygomatic.
Yes, sir. Lower buccal, lower
upper buccal.
Yes, sir. Buccal.
Cervicofacial will give lower buccal, marginal glandular, and cervical.
Yes, sir.
So if you have to save one branch, which branch will you preserve? Most important branch.
Now supplying the orbicularis aculi muscle.
Eye. So zygomatic branch, you know, the one going to the orbicular.
Yes.
Thank you. So, sir, Dr. Hitesh, Dr. Rajesh, please ask other questions.
I think Kanagvel sir has already asked us to finish it up in 10 minutes. So if
I think we're done.
We are done. Then we can go for next case if Srivastav sir and all agree.
Yeah, thank you. Thanks for the opportunity, sir. And post-operative, again, you will discuss the management in the tumor board with the oncology colleague and discussing the pathology report. And if there is any special type of tumor, then certainly you can give chemotherapy. Otherwise, post-op radiotherapy is mandatory. For all recurrent and malignant tumors of the parotid, post-op radiotherapy is mandatory. And give counseling to the patient that sometimes radiotherapy can cause damage to the facial nerve. Right? Radiotherapy can cause damage to the facial nerve. It may be temporary, but at least you have to give explanation. Thank you.
Thank you, sir. Ajay Khanna sir. Ajay Khanna sir is there.
Khanna sir joined?
Yes, sir. I saw him is there. Or we can go. Khanna sir, can we go to the next case? Thank you, Prabhu.
Yes, sir. Thank you, sir.
Thank you. Well done.
Sir, you can stop sharing. The other person forgot his name, sir. Kavan, please.
Yes. So should I start?
You can start, but introduce yourself.
Yes. So good evening, everyone. Myself, Dr. Kavan Manek from a second-year general surgery resident from NHL Municipal Medical College. I would like to thank Dr. Hitesh Andaria sir, Dr. Nilesh Patel sir, and Dr. Varun Bajaj sir for helping me through this. I would like to start my case. A 60-year-old gentleman, a permanent resident of Daryapur, Ahmedabad, a tailor by profession, presented to OPD with chief complaint of swelling in right groin for 3 months. Patient was apparently normal 3 months back. Then he noticed a swelling in standing position in his right groin, which gradually increased in size. It appears immediately on standing and while walking, and used to disappear completely immediately on lying down with no history of swelling in the scrotum. Patient also gives a history of off and on constipation for past 1 year without any history of bleeding, PR or weight loss. No history of pain over the swelling or in the abdomen, vomiting, abdominal distension. No history of heavyweight lifting, chronic cough, difficulty or straining at urination, nocturia or similar complaint on the opposite side. No past history of tuberculosis, any surgery or hospitalization. No history of hypertension, diabetes mellitus or COPD. Patient is not on any medications No history of similar complaints in any of the family members. Patient is on vegetarian diet with adequate sleep and appetite, with normal bladder habits, with constipation off and on for past 1 year, with no addictions. I would like to summarize my case as a 60-year-old gentleman presented to OPD with complaint of swelling in right groin region for past 3 months, which gradually increased in size, appears immediately on standing and while walking, and disappears completely immediately on lying down.
Did you take any family history?
Yes, sir. There was no significant family history of the similar complaints in any of his brother.
Why did you take that history?
Sir, considering the history given by the patient, I feel the provisional diagnosis is a case of hernia, and hernia may occur
Why did you take family history?
Because, sir, according to my diagnosis, it is significant that the disease can be also be seen in the family members.
How and why?
Yes, sir. Hernia might be associated with collagen vascular disease, in which the defective collagen synthesis is there. So, if due to defective collagen synthesis, there will be weakening of the lower abdominal wall. So, it might predispose the patient to develop hernia.
Like disease, like?
Sir, sir, Ehlers-Danlos syndrome, in which there is a defective collagen synthesis.
Okay.
Ehlers-Danlos syndrome.
Sorry, sir.
जिसमें मैंने कहा flexibility होती है
मुझे कब बताया?
एक दफा बताया था मैंने जो flexible होते हैं वो पूछ रही है.
History of no medication.
Am I audible?
Yes, sir.
So why this history and what kind of medication were you thinking about?
Sir, if patient has any chronic illnesses for which he might be taking any medication, sir.
Like? And how does that have a bearing on this present scenario?
Right, sir. There won't be any like I was just taken for the routine medical history which we take, like so not specific for this case.
So it was just as a routine part that you took a history of medication.
Yes, sir.
Did you mention any history of trauma? I may have missed it, but did you mention any history of trauma?
No, sir. I haven't mentioned it.
Did you mention any history of past operation?
Yes, sir. I have mentioned the history of surgery. Yes, sir.
Like surgery, like?
Sir, usually, sir, in case of hernia, which is my provisional diagnosis, again, if there is a history of open appendicectomy, then nerve such as ilioinguinal nerve might get damaged if the incision is extended lower down. So then inguinal damage to the ilioinguinal nerve will lead to the transaction of the muscular fibers, which will like internal oblique and transversus abdominis, which will weaken
the appendectomy or some other operation?
Sir, usually like any operation, like any lower abdominal operation is significant because
like?
Sir,
let's not generalize the things. Let's talk about another specific operation. When you said open appendectomy, agreed.
Yes, sir.
Any other operation with a similar incision? You can think of some operation. What about an open ureterotomy?
Yes, sir.
Okay. So, right. So when you're giving this incision, normally you're giving it where?
Sir, at the McBurney's point, which is the junction of the medial 2/3 and lateral 1/3 of the spino-umbilical line.
Okay. Right. So when you're giving that incision there, which nerve is most likely to be damaged?
Sir, ilioinguinal nerve.
What about the iliohypogastric nerve? Which lies higher, which lies lower?
Sir, ilioinguinal is higher and iliohypogastric is below.
Are you sure?
Yes, sir.
Are you sure?
Yes, sir.
Or is it the reverse that we're talking about?
Sir, I feel ilioinguinal is above and iliohypogastric is below, sir.
Ilioinguinal lies below, iliohypogastric lies above. Okay. Now, where does this nerve come into play when you're giving this incision? In which plane?
Sir, between the internal oblique and the transversus abdominis muscle.
Are you sure?
Yes, sir. At the near the anterior superior iliac spine, the ilioinguinal nerve will pierce the transversus abdominis muscle to enter the plane between the internal oblique and the transversus abdominis muscle, sir.
Exactly. So where you're giving an appendectomy incision, the
Yes,
nerve is more likely to lie in the external oblique.
sorry, sir, I cannot hear it, sir.
बैठा हुआ लड़का देखो वो लाइव है तो ये
Dr. Asim said, Khan, please mute yourself. Dr. Asim.
Okay, do you know any other complication if the nerve is not injured, cut? Any other complication can develop which is more severe?
Am I audible now? Yeah, okay.
Yes, sir, you are audible. Sir, please ask.
Yeah.
Sir, again, not audible. Sir, not audible. Not audible, sir. So, Kavan, do you know any other complication? The nerve is not injured during keeping the incision. Any other way to damage the nerve and have some grievous complaints post-operatively?
Sir, while closing the external oblique aponeurosis, the nerve may get entrapped while taking the external oblique, by closing the external oblique.
So how will this patient present?
Sir, patient will post-operatively will have persistent pain in the groin at the medial aspect of the in the region of pubic tubercle and the root of the scrotum, medial and yes, sir, in medial side of the groin region, sir.
So, what is your summary? Let us go to your summary.
Yes, sir. My summary is a 60-year-old gentleman presented to OPD with complaint of swelling in right groin region for past 3 months, which gradually increased in size, appears immediately on standing and while walking, and disappears completely immediately on lying down.
Okay. So, what is your probable diagnosis from history?
Sir, more like sir, likely direct inguinal hernia, sir.
Why do you say it is hernia?
Sir, hernia because the swelling is reducible. So, the patient gives a classical history of appearance of swelling on standing, and immediately the swelling gets disappears on lying down.
So what does it mean? Immediately disappears?
So that, sir, more probably direct hernia, because if in case of indirect hernia, it will take some time to get reduced.
An elderly male.
Yes, yes, sir.
Okay. Rajiv sir. Sahai sir.
Yeah, you've got the. Actually, I missed. I was slightly busy. Okay, Manek, what's it? Have you done the examination?
Sorry, sir.
Have you done the examination?
Yes, sir. Oh, yes.
Okay.
So, the patient is conscious, cooperative, well-oriented to time, place, and person. Patient is averagely built and nourished. The patient is vitally stable with temperature normal on palpation, pulse rate 78 per minute, respiratory rate 18 per minute, blood pressure of 126 by 78 mm Hg. Karnofsky's performance score is 90, and no icterus, pallor, cyanosis, clubbing, edema, or lymphadenopathy. Systemic examination of cardiovascular, respiratory, and central nervous system does not reveal any abnormality. So, examination of the inguinal scrotal region. I have examined the patient in standing and supine position. On inspection of the right inguinal-scrotal region, a single globular swelling of 5 by 5 centimeter is appreciated in the right inguinal region just above the medial half of the right inguinal ligament extending up to the root of scrotum, which appears immediately on standing, while walking, and on cuffing in supine position, and it reduces completely immediately on lying down, with overlying skin normal and no visible peristalsis. On inspection of the left inguinal-scrotal region, an impulse on cuffing is appreciated approximately just above the medial half of the inguinal ligament, with no evidence of any swelling in supine or standing position. The penis is slightly deviated to the left side. The skin over the scrotum appears normal. Bilateral testes appear normal. External urethral meatus appears normal. So these are the images on standing and supine position.
Go fast.
Yes. On palpation of the right inguinal-scrotal region, a single globular, non-warm, non-tender, dewy swelling of 5 by 5 centimeter is appreciated in the right inguinal region above the medial half of the right inguinal ligament, extending from 7 centimeter above and 7 centimeter medial and 5 centimeter below the right anterior superior iliac spine up to the right pubic tubercle. It appears on standing, walking, and while cuffing in supine position also, and it reduces completely immediately on lying down. On performing deep inguinal ring occlusion test on right side, it is negative. And on palpation of the left inguinal-scrotal region, an expansile impulse on cuffing is palpable just above the medial half of the left inguinal ligament, with no evidence of any swelling on supine or standing position. The deep inguinal ring occlusion test on left side is negative. No Molgagnis bulge is appreciated on Valsalva maneuver or on raising the head or the leg. Complete retraction of the preputial skin is possible. Urethra is normal with no palpable thickening or the stones. Bilateral testes are normal on palpation. On auscultation, bowel sounds cannot be heard over the swellings. On per abdominal examination, the abdomen is flat with umbilicus centrally placed, with no visible peristalsis, scars, or redness over the skin of the abdomen. On palpation, it is soft and non-tender with no organomegaly or any palpable lumps. No evidence of any free fluid in the abdomen. On per rectal examination, it is normal with no prostatomegaly. Back and spine are normal. So I would like to summarize my case as a 60-year-old gentleman presented to OPD with complaint of swelling in right groin for past 3 months, which gradually increased in size, which appeared while standing and walking, and used to disappear completely immediately on lying down. On examination, there is a single non-warm, non-tender, globular dewy consistency, reducible 5 by 5 centimeter swelling with an expansile cuff impulse on cuffing in right inguinal region, which appears on standing, walking, and cuffing, and it reduces completely immediately on lying down. Right side deep inguinal ring occlusion test negative, and an expansile cuff impulse on cuffing is palpable just above the medial half of the left inguinal ligament, with no evidence of swelling, and left side deep inguinal ring occlusion test is negative. So my diagnosis will be right-sided, uncomplicated, reducible, incomplete direct inguinal hernia with omentocele, and left side developing direct inguinal hernia.
Okay. So what do you mean by developing?
Sir, developing means the swelling is not appreciable in either of standing or supine position. Only an expansile cuff impulse is appreciable. And I suspect it as hernia because it is already present on the contralateral side.
No, hang on. No. That. I just asked you what do you mean by developing. Is there a better word for it? Is there a more scientific word for it than developing? I've never heard of this thing called developing.
Sir, occult would be another term. Occult
would be won't be managed. It's a bubonocele. What's a bubonocele?
Sir, bubonocele will be an indirect type of inguinal hernia in which the sac is present within the inguinal canal between the internal ring and the external ring.
So what do you think this is?
Sir,
isn't it a bubonocele?
No, sir, because it is
because coughing is coming out.
Bubonocele is a type of indirect inguinal.
So what is this?
No.
No, not necessary.
You have a swelling where you can perform all the tests, and you say it's an occult swelling, nephrotic swelling. You did a deep ring occlusion test, did you not?
Yes, sir. Yes, sir.
Then that obviously means there is a swelling.
Other faculties, please mute yourself.
Hello, Dr. Shashank. Dr. Shashank.
Some disturbance of it.
Kindly mute Dr. Shashank.
ಅದು ತಗೊಂಬ ಒಂದ್ ಸ್ಪೂನ್ ಎಷ್ಟು ಬರುತ್ತೆ ಹೆಂಗ್ ಬರುತ್ತೆ ನೋಡೋಣ.
Rajesh sir, you are host. Sir, you can mute, sir.
I'll do that.
ಡಬ್ಬಿ ತಗೊಂಡ ಒಂದ್ ಸ್ಪೂನ್ ಹಾಕಿ ನೋಡೋಣ ಹೆಂಗಿದೆ.
Okay.
Okay, so you do a three-finger test?
Yes, sir. I have performed the three-finger test, the Siemens test. But, sir, for differentiation of direct and indirect inguinal hernia, the deep ring occlusion test would be sufficient enough. And
no, how do you do? How do you do a deep ring test? Where are the fingers put?
Sir, the thumb on the affected side will be placed in the deep inguinal ring, which will be identified as 1.1 to 2 centimeter above the femoral pulsations on the same side. We occlude the deep inguinal ring with the help of the thumb of the same side after reducing the swelling, and we ask the patient to cough. So if the swelling is appreciated medial to the occluded deep ring.
Just a minute, let me interrupt you. Are we talking about the three-finger test or are we talking something else?
Sir, I'm the deep inguinal ring occlusion test.
What is the position of the deep inguinal ring?
Sir, it is 1 to 2 centimeter above the femoral pulsations.
1 to 2, no.
Not 1 to 2, not 1
Femoral pulsation is
1.25 centimeter.
Yeah, 1.25 centimeter above the femoral pulsations.
Why taking the marking of the femoral pulsation?
Femoral pulsation? Yes.
Sir,
point.
Yes, sir. Is that the side from where you take the marking, the femoral pulsation? Or is it infernal ligament?
So we will take the mid-inguinal point between the pubic symphysis and the anterior superior iliac spine. So we will mark the mid-inguinal point and it
1.25 centimeters above the
mid-inguinal point,
right?
Yes, sir.
Okay, so that is one. The second finger?
Sir, the second femur will be in the superficial inguinal ring, which is 1 centimeter above and medial to the pubic symphysis, sir.
What about the third finger?
Sir, third finger will be 4 centimeter below and lateral to the pubic tubercle.
Okay, 3.75. Okay, we'll take that. Now,
yes,
once you have reduced it and you put these three fingers, right? That's what you
yes,
do.
Sir. Yes,
okay.
Sir.
Now, what do you do then?
Sir, then we ask the patient to close the nose and blow against it and blow air. Valsalva's maneuver.
Okay, so with all the three fingers in position, right?
Yes, sir.
So what could be evident?
Sir, if the impulse is felt on the ring finger, that is at the internal ring, it is probably an indirect inguinal hernia. If it is felt on the middle finger placed at external ring, it will be a direct inguinal hernia. And if the impulse is felt at the index finger placed at the saphenous opening, it will femoral canal, sir. It will be an femoral hernia.
Suppose you have all the three fingers in position, you ask the patient to cough.
Yes,
you
sir.
don't feel any impulse on any of the fingers and you see a visible swelling medially. What is that? Did you get my question?
Yes, sir. So varicocele, sir.
Varicocele? You're getting a swelling, visible swelling in the suprapubic area medial to your finger, which you have put over the SIR. So
Yes.
what is that?
Sir, I don't know.
You know of any other hernia in that particular area? Apart from direct, indirect inguinal hernia, any other hernia you know of?
Sir, prevesical hernia, sir.
Is that a prevesical, some other name? Yes, you'll get it.
So supravesical hernia.
Supravesical, good. So which supravesical hernia are we talking about?
Yes, okay.
Which supravesical hernia? An external supravesical hernia. Supravesical hernia can be internal and external.
Okay.
So that is one thing we tend to forget when we are doing a three-finger test. The first part of three-finger test is that you ask the patient to blow the nose and then you look for a visible swelling. And then you start looking for impulses on any one of your fingers, deciding whether it is a direct, or indirect, or a femoral hernia. That's what you do.
Okay.
Okay.
Okay, sir. Yes,
and
sir.
Please do not use this word developing in future. There is no scientific word like developing. It has to be a bugnosia. Right?
Okay, sir.
You're able to do a DIR, a deep ring occlusion test. Now, did you do a superficial ring invagination test?
Yes, sir. I have performed it, but I have not mentioned it, sir.
Why?
Because, sir, as I said, the most reliable test to differentiate between direct and indirect inguinal hernia would be a deep ring inguinal ring occlusion test, sir.
Agreed. This may not be reliable, but would you do it?
Sir, we can. But if the patient is uncomfortable and he feels the pain on doing the test, we will avoid it, sir.
So you should have said, I should never do it. That is one test which is no longer recommended. A superficial ring invagination test is no longer recommended. You shouldn't do it. It's very painful to the patient. So you just rely on two. One, you do a ring occlusion, and third, you do a 3-finger test.
Okay.
Right? Yes. So you have a bilateral direct inguinal hernia.
Yes, sir.
That's what you have.
Yes, sir.
So why do you say uncomplicated?
Sir, because it is reducible and the cough impulse is also present.
No, that's why you call it a uncomplicated.
Yes, sir. The cardinal features of the hernia will be present in an uncomplicated case, and when a hernia gets complicated, any of the two cardinal features will get compromised.
So, which complication are you looking for?
Sir, complications might be, sir, hernia may become irreducible, and it may get obstructed or incarcerated. It may get strangulated. Yes, sir. So these are the
common. So what is the common cause for irreducibility?
Sir, the hernia may become irreducible because of adhesions between the sac and its wall, and the sac and its content, the wall of the sac and its content, and the adhesions within the content of the sac, sir. So these are the two reasons, sir.
Okay, why did you say omentocele?
Sir, omentocele because, sir, vowel sounds, first of all, the vowel sounds cannot be heard on auscultation over the swelling. That is the one reason, sir.
No,
Dewey consistency also, sir. Dewey consistency also.
What about the reducibility difference between a omentocele and what is the other one? What's the other name?
Enterocele.
Enterocele. Good. So what's the difference between the two?
Sir, enterocele, the first part of the reduction will be difficult, and the second part of the will be easy as compared to omentocele, for which the first part will be easy to reduce and the second part will be tough to reduce.
Exactly.
Yes.
So that's right. That's right. So, yeah, anybody else with a question? I'll come with more questions later on.
Srinivasan, sir.
Yeah.
He has answered well, sir, every question.
Rajiv, sir, you can continue.
Yes.
Yes, sir.
Okay, so now how are you going to approach this patient?
Sir, first I will carry out routine blood investigations for like complete hemogram, renal function test.
Why would you do that?
Sir, if any subclinical infection is present anywhere in the body, we can pick it up, sir. For
why are you looking for infection in this patient?
Sir, as a part of routine investigation, we'll also, sir, infection might be present, and also as there is no clinically evident pallor in this patient, but the hemoglobin might be low. So we will also come to know about the hemoglobin of the patient.
In a patient who has come to you with hernia, what is the first decision making to be done? Even before you go ahead with investigations.
Sir, we will explain the patient that the surgery is the only treatment. First of all,
why would you do that? Do you think every hernia requires surgery?
Sir, not in this case, because it is like the patient has no any complaint of pain or it is not symptomatic, and usually direct hernias do not get complicated. But so if patient does not want to get operated, we will counsel him, and but we will explain him that the surgery is the only choice for definitive treatment.
So the first answer should have been that I would first of all decide whether this patient really requires surgery or not. Yes, every patient with hernia does not require surgery.
Yes, sir.
It is a symptomatic hernia or a hernia where there is an increased likelihood of future complications that you would like to deem surgery to be necessary.
Yes.
Okay. So straight away, don't jump onto the bandwagon of doing this investigation and that investigation. First of all, decide whether they want to do it, whether the patient wants to have it.
Yes.
Dr. Manek, why has the patient come to you?
Sir, patient has complained of swelling, sir. Swelling in the right groin.
So is it bothering him?
Yes, sir.
So you'll tell him that you have to counsel him and give him the options.
So which
and take his opinion whether he wants a surgery or not.
Yes, sir.
Right?
Yes, sir.
So which symptom would warrant a surgery in this patient? His age is what?
Sir, 60-year-old male, sir.
Okay, so and a direct mobile hernia.
Yes, sir.
Yes. So what would warrant a surgery in this patient?
Sir, local discomfort to the patient.
Discomfort which is not compatible with daily
activities.
Daily activity, right?
Yes,
the most common is pain or intermittent episodes of obstruction. Or any other complication. That would be a patient who has to have surgery. Otherwise, you have to counsel the patient, and the patient may or may not want surgery because he really does not have any symptoms as such. You never mentioned. Did you mention pain in this? I was not there in the initial part. I was not there. I'm sorry, I was not there. I was slightly late in joining. That's my point.
Yes, sir. I mentioned it.
Okay, you did mention. I'm sorry about that. Right. So now you decide that surgery is to be done. Okay.
Yes, sir.
Now, how do you proceed?
I'll just ask you one question, Manik, before that.
Yeah, please,
yes, sir.
You said that direct hernias usually don't obstruct.
Yes, sir.
Do you know for a direct hernia which presents with obstruction? I mean, it's a way out question, but if you can answer it, I'd be happy. It's called a Busoga hernia. Have you heard of that? B-U-S-O-G-A, Busoga hernia?
No, sir.
Okay. Okay, I'll tell you. This is Busoga is an area in Uganda and southern Sudan. Right?
Yes, sir.
Where women have this defect in the conjoint tendon, which is very small, and they carry stuff on their head and they develop a direct hernia, which presents with. So it's called a Busoga, B-U-S-O-G-A, Busoga hernia.
Okay, sir.
Okay. Professor Sina, please continue, sir.
Yeah, okay. So now you've decided that you want to go ahead and do surgery in this patient. So let's not talk about the routine investigation. We'll leave that for another day. Now let's come directly to the hernia. Right? So what would be your choice in this patient? And why?
Sir, for investigations?
No. Now I want to tackle this patient now. Would I like to? Would I be interested in doing some investigations apart from the routine?
Yes, sir. I would like to perform an ultrasound of the inguinal-scrotal region and the abdomen.
Why would you do that?
Sir, ultrasound of the inguinal-scrotal region to assess the exact sides of the defect. And as the left side, it is occult or the occult inguinal hernia, we would like to confirm it, sir. And
I have strong objections to the word of occult that you're using repeatedly. Don't use the word occult in this patient. There's nothing occult.
Okay, sir.
You can see a spelling, you can do a deep link occlusion test. It's not occult anymore. Anyway, so why would you like to measure the size of the defect? Why you want to do that in an inguinal hernia?
Sir, in case of hernias with larger defects, sir, though the treatment of choice is mesh repair, but if at all we are planning for tissue repairs, then the tissue repairs won't be suffice for hernias with larger defects, sir.
No, come again. You want to do an ultrasound because you want to measure the defect to decide whether you want to go in for a tissue defect or a mesh.
No, sir. Sir, if at all we are planning for tissue repair, then it is then the tissue repairs cannot be done.
No, I'm asking you, what would you do? Let's restrict ourselves to you, your choice, and then we'll talk about why.
Sir, I would like to have a mesh repair, sir, for open mesh repair.
Okay, Manik, do you have to do, what are the indications for doing a tissue repair?
Sorry, sir?
What are the indications for doing a tissue repair?
Sir, there are no specific indications as such, like only tissue repair has to be done on this, and sir, it depends upon the surgeon's choice, sir.
Surgeon's choice?
Yes.
Do you have a choice that I will do tissue repair and not do a mesh repair?
So the gold standard is tension mesh repair only, sir.
So don't mention tissue repair.
Okay.
You only do it in if you don't have a mesh. Some people do it in emergencies. They try and do it with that. Don't put a mesh, but that is also out now. You can put a mesh even in emergencies. Okay.
Okay, sir.
So don't mention that. All hernias require some support.
Okay, sir.
So you're doing a mesh repair, okay?
Yes, sir.
Now the second question is, what approach for this mesh repair?
Sir, I would like to have an open anterior approach for this patient.
Open anterior approach.
Yes,
Would you
sir.
like to be more specific? What is an open anterior approach? Be more specific. Now we are talking specific.
Lichtenstein repair, sir.
So say that I would like to do a bilateral Lichtenstein's repair.
Yes, sir.
Suppose the patient wants a laparoscopic repair, then
yes,
he says,
sir,
I just want a laparoscopic.
Sir, laparoscopic repair is better suited for bilateral inguinal hernia.
No. Yes, no, I'm not asking whether it's better suited or not better. I'm asking the patient says, you say I'll do a Lichtenstein. He says I want a lap. What will he do now?
Sir, we can offer the patient laparoscopic surgery.
I'm not questioning of we. I'm questioning of you. I'm not.
Sir,
I'm not saying
I won't do it at this stage of point, sir. I would, sir, ideally refer to a laparoscopic hernia surgeon.
Okay, good. That's it. Or you you'll call for help. You'll not refer. You just call a laparoscopic surgeon to help you out.
Okay, sir.
Okay. Any other option other than Lichtenstein repair?
Sir,
for bilateral?
Yes, sir. Reeve-Stopa approach can be Reeve-Stopa repair for the
Stopa's repair.
Yes, sir.
Okay. Professor Sinha, sir, please, sir.
So you basically have two choices: either you do an open repair or you do a posterior repair, which is a laparoscopic repair. You know of any open posterior approaches apart from Reeve-Stopa repair?
Sir,
in a open hernia repair, what is an anterior repair and what is a posterior repair?
Sir, anterior repair is when we open the inguinal canal and we place the mesh on the floor of the inguinal canal. And in posterior approach, we go from we enter the extraperitoneal space that is between the fascia transversalis and the peritoneum, and we place the mesh over in the preperitoneal space, sir.
Exactly. That's right. The answer is right. It has to be a posterior to the posteriormost layer. Now,
yes.
That posteriormost. So, according to that, based on this definition, what would you like to call a Bassinese repair? Is it an anterior repair or posterior repair?
Sir, it is an anterior repair, sir.
Why would you say it's anterior repair?
Sir, because we do not enter the preperitoneal space in Bassinese repair.
So, is it that you have to enter the preperitoneal space to call it a posterior repair?
Sir, it is not a, first of all, it is not a mesh repair, sir. So,
no. The question is it necessary to enter the preperitoneal space, or it is something else which is called anterior repair? You said previously anterior and posterior very nicely. Now you have to just twist the word to make sure that you are correct. What do you don't do in posterior repair?
Sir, open the inguinal canal.
Don't open.
Yes, sir. In anterior approach it is opened, and in posterior approach it is not open.
No, then how are you going to enter into the posterior part?
Sorry, sir.
How would you enter the posterior part in an open repair if you're not entering through the inguinal canal? Are there other alternatives available?
Sir, sir, as in case of the Reeve-Stopa repair, we open the.
That's what I said. Apart from that, my question was apart from Reeve-Stopa. Because the problem these days is that we just know of Bassinese repair and we know of the laparoscopic repair. We have forgotten the other posterior repairs.
Sir.
Knowledge, I think, is necessary. At least you should know these repairs. There's no justification not knowing those repairs.
Is there any difference in putting the incision in Bassinese repair or hernioplasty versus preperitoneal mesh plasty? Where is the difference?
Sir, in open preperitoneal mesh plasty, the incision is transverse and relatively medial on the medial aspect, sir. And in case of the classical open repairs like Bassinese and Lichtenstein, we place the incision above and parallel to the inguinal ligament, sir. Medial half of the inguinal ligament.
Not exactly correct. The first one is not medial; it is above. You don't enter through the inguinal canal at all.
So
yes, sir.
As to the preperitoneal space.
We put it above deep ring.
Yes, that is why it's placed above the inguinal canal, and you straight away go into the preperitoneal space. Open repairs. Anyway.
Yes.
Right. Do you know anything about Schulde's repair?
Yes, sir. Schulde's repair is a 4-layer repair, in which we primarily do the double breasting of the fascia transversalis, and we suture the external oblique and the transversus abdominis with the reflected part of the inguinal ligament in 4 layers.
What is the problem with the shoulders repair?
Sir, shoulders repair, as we suture the as we approximate the medial and the lateral portions, there is development of tension. It is a tension repair.
But did you know that shoulders repair is considered to be one of the preferred modes of doing a hernia raphe?
Yes, sir.
Even considered better than Bassinese or modified Bassinese repair. So if what you say is true, then that is not correct.
So recurrence is also more.
Is was a recurrence with shoulders repair?
Yes, sir.
No, what yes, sir?
Sir, it is relatively more in shoulders repair as compared to Lichtenstein repair.
Relatively more. What does more or less mean? More than what or less than what?
Sir, more in compared to Lichtenstein's repair, sir.
So there has to be a figure to it. A more could be more than 5%, it could be more than 15%, it could be more than 20%. What are we looking at? Which figure are we looking at?
Sir, incidence of recurrence.
Yes, that's what I'm asking you. In a shoulders repair, incidence of recurrence is what?
Sir, around about 10%, sir.
10%? Don't tell me.
No hernia surgery would be
Someone, if you don't know, say that I don't know, sir.
Yeah, just say I don't know.
Don't attempt all questions to answer if you don't know.
Okay. Any hernia repair with 10% should not be done. Okay.
Okay.
So we're looking at
any surgeon with more than 10% should not be operating hernia.
Yes. That we
looking at 1 to 2%, less than 1%. But the problem with shoulders repair is that the reported rates from the shoulders clinic are not easily replicable.
Reproducible.
Yes. It's very difficult to replicate a surgery.
The shoulders repair. They're not reproducible. You try doing a shoulders repair and you'll have an increased recurrence rate. They do put out a figure of about 1%, even in certain cases 1, but that's only for the shoulders. And that is why, one, despite the fact written textbook as considered to be a very good hernia raphe, but otherwise, Bassinese or modified Bassinese is still preferred by a lot of surgeons over a mesh repair when they don't have a mesh. Right?
Okay, sir.
Okay,
Right.
have you heard of PHS? This is out now, but there was a system called PHS, which was quite famous, quite used. Have you heard of it, Manak?
No, sir.
It's called a Proline hernia system.
Okay.
Which had a dual mesh, which had a mesh in the preperitoneal mesh and a mesh on the posterior wall, both anterior and posterior, with a plug in between.
Okay.
So what are the problems with PHS? You don't know PHS. The problem with PHS, Dr. Sahai put it out, was that it's no longer being used very commonly for the simple reason that you're trying to load a lot of foreign material into the body. And now the basic aim is that you use the minimum amount of foreign material. Mesh is the foreign material. It does lead to stimulation of the immune system. It's not that any of the mesh is inert. No mesh is inert. They all have their own problems. So that's why they say that and that's why we now working towards macroporous meshes rather than microporous mesh, because you want to implant less and less amount. Right.
Yes.
Now you have decided to do a bilateral laparoscopic. Okay. Now, doing a bilateral laparoscopy, what would be your choice? What are the options, first of all?
Sir, we have two options: transabdominal preperitoneal approach and totally extraperitoneal approach.
Any third one, which is now recently come into fore?
Sir, extended TEP, sir, totally extraperitoneal repair.
It started in 2012 for the first time, but now being done more commonly, less commonly for inguinal hernia, more commonly for some other hernia. But then, yes, that is a possibility. Which would you choose, a TEP or a TAPP?
Sir, ideally, I would do a totally extraperitoneal repair. But, sir, yes, sir, I will do a totally extraperitoneal repair.
You'll do a TEP. Why would you do a TEP rather than a TAP?
Sir, because in transabdominal preperitoneal approach, first there is more risk of injury to the intraperitoneal organs like bowel and bladder and all the intraperitoneal the structures. And
there's a possibility, although level 1 evidence is still lacking. Anyway, number 2.
And sir, in case of TAPP, we have to close the peritoneum from internal side. So it is difficult skill to acquire over a period of time, sir.
So you're saying it's technically difficult to do a TAPP rather than TEP?
No, sir. A TAPP is easier, but sir,
Just now said closing the peritoneum would be problematic.
Sir,
you're contradicting yourself. Which is easier to learn? Tell me. TAPP?
Sir, TAPP, sir.
TAPP is easier to learn. So yes. It's not always correct to say. And there's hardly anything to choose. There are reports and reports galore saying which one is better than the other, and none of is better than. You are proficient in any one procedure. That is the procedure is the best then that should be done in that particular patient. Right?
Okay. Yes.
Now, when you're doing a Lichtenstein's repair, tensionless repair, why is it not tensionless repair?
Sir, because we usually don't approximate the posterior wall, we only strengthen the posterior wall by placing the mesh.
First of all, let's talk about one basic difference between hernioplasty and raphe. What is the difference?
Sir, in herniorrhaphy, we strengthen the posterior wall. That is the basic. And in case of herniorrhaphy, we strengthen the posterior wall by keeping a prosthetic material, sir.
Is a suture not a prosthetic material? The suture that you use in Bassanese repair, isn't that a synthetic material?
Yes, sir. It is a synthetic material.
Even that is synthetic reinforcing. Is that the difference between hernioplasty and herniorrhaphy?
Technicality. What is the difference in technicality?
Sir, we do not close the posterior wall in hernioplasty, sir.
Just remember one single word: bridging and approximation.
Okay.
Never forget these two terms. In one year, approximating. Approximating what?
Sir,
in which area approximating?
Sir, posterior wall of the inguinal canal.
In which? Open or hernioplasty?
Sir, herniorrhaphy, sir.
Herniorrhaphy. So you're approximating. What are you approximating?
Sir, we approximate conjoint tendon with the inguinal ligament. Reflected part of the...
Don't use the word conjoint tendon. Why? Why should you use the word conjoint tendon? Tell me.
Sir, it is hardly present in 5% of individuals.
So then why use that word?
Yes, sir. So the transversus abdominis and the internal oblique. Sir.
The arching fibers of the tarsus abdominis and oblique, preferably just tarsus abdominis. That should be better.
Yes.
Right?
Yes.
So
yes.
You're approximating it to the inguinal ligament
yes.
or to the iliopubic tract. Agreed?
Yes, sir.
In hernioplasty, what are you doing? You're bridging it like a bridge.
Yes.
So what is the main problem with a raphe?
Sir, tension. By approximation of the posterior, by the bridging approximation of the posterior wall will create the tension, which
that
will.
Is one. Number two. The suturing that you do.
Yes.
What should you be careful about when you suture in herniorrhaphy?
Sir, entrapment of any nerves, sir.
Nerve? Any nerve? Which nerve are you talking about?
Ilioinguinal, ilioapogastric, and genital branch of genitofemoral.
No, don't make it a generalized thing. The suture that you take, where and which nerve gets entrapped? Which nerve is lying over the arching fibers?
Sir, genital branch of genitofemoral nerve.
Is it lying over the arching fibers? Or is it part of the inguinal cord? It enters the inguinal cord.
So it is not a
nerve arches over the arching fibers. Which is that nerve?
Sir.
You got to play about with only 3 nerves, right? The choice is only 3, limited to 3.
Sir, iliohypogastric. So I am not sure about it.
Yes. The answer is correct. And now you know why your first answer was wrong. Appendectomy. Iliohypogastric lies over the arching fibers.
Yes.
The inguinal nerve lies below. Now you get it.
Yes. Yes, sir.
So when you're taking those sutures, one, you have to be very careful that your needle does not include the iliohypogastric nerve. Number 2, the sutures should not be too tight. Why? Tell me.
Sir,
why should it be too tight?
Sir, if the sutures are tight, then it will develop more tension, which will
is that
it will prone for the development of recurrence.
What else happens with tighten sutures? What
Sir,
does
the vascular compromise might get?
Yes, leading to what? Leading to what? What will happen to the muscle fibers?
Sir,
if you tighten a muscle fiber, the vascularity goes. So what happens to the muscle fiber?
Sir, the vascular, it will, post-operative pain will be there, sir.
There, but what will happen to the muscle fiber? It will weaken, my dear sir.
Yes, sir. It will be more prone for recurrence, sir.
Yes, so that's what I'm saying. When you're doing a vascular repair, which still, I think a majority of surgeons are doing it, then you have to be very, very careful that those sutures that you apply, you don't drag the fibers down. Why? Because dragging the fibers down also disturbs the anatomy. What is the basic principle of surgery? Basic principle of surgery is trying to do what? Reposit the anatomy and physiology to as near normal as possible.
Possible. Yes, sir.
That's what the whole aim of surgery is.
Yes, sir.
Trying to do it. Now here, if you're dragging the arching fibers down, are they now lying in a unnatural position or a natural position?
It's an unnatural position.
What happens to the sphincter mechanism of the posterior wall? It goes?
Yes, sir. It gets weakened, sir.
You don't have any mechanism remaining behind.
Yes, sir.
Right? And that is why plasty is preferred over herniorrhaphy. That is the reason why you should prefer that.
And that is why even Schultes is better than Bessinis theoretically, because there you do not make any tension on sutures. You touch the fascia transversus, which is not bringing or keeping apart any muscles. And it's a different, it is exactly the where the defect lies, to be specific.
Yes, sir. Yes.
And that is exactly what a modified Bessinis does. You're trying to approximate two structures lying in the transalis fascia. What are the transalis fascial analogs? You have heard of this term, transalis fascial analogs?
No, sir.
We know that the transalis fascia in the inguinal region is different from transalis fascia in the supraumbilical region. Do you know that?
No, sir.
Is it layered down? You don't know about the layers of the transalis fascia in the inguinal region? Layer number 1, 2, and then of course the third one?
Sorry, first is the parietal layer and the other is the visceral layer. Parietal layers, it covers the transversus abdominis.
So there are two layers. That's what I'm asking. There are two layers.
Yes, sir. Yes, sir.
And there is modification of the transalis fascia in inguinal region. It is thickened at places, giving rise to what?
Continuation.
What are transalis fascial analogs?
Continuation becomes what? And thickened.
What is the ilipubic tract?
Yes, sir. It is a modification of fascia transversalis, sir.
It is lying parallel and behind the inguinal ligament. That's part of the transalis fascia.
Yes, sir.
Right? What
Yes,
is the other part of transalis fascia which is just lying parallel and behind the arching fibers? What's that known as? That is the thickening, which is used for doing a pure transalis fascial repair. When you're doing a herniorrhaphy. That's known as a transalis fascial arch. Okay?
Okay,
you have
sir.
to read this up. Please go and read this up. I'm not going to go into detail of transalis fascia here, but it's a very, very interesting fascia. You have to read it up. And the third part of transalis fascia in the inguinal region that we have to know of is what is known as transalis fascial sling.
Okay.
What is a sling? This is basically a sling which is forming the part of the deep inguinal ring. After all, what is the deep inguinal ring? It is an opening in what?
Fascia transversalis.
Fascia transalis.
Yes, sir.
And there are pillars to it. What are those pillars? The pillars of DIR are basically made of the transalis sling. They are again thickenings. They are again thickenings. So when you're narrowing the deep inguinal ring, what is that repair known as?
Sir, Little's repair.
Little's repair. So where do you apply the sutures? You apply to transalis fascia.
Yes, sir.
And that is the part which can hold the suture, that thickening. What is the transalis fascial sling? And the fourth part is the Henle's ligament. So these are the four analogs of part transalis fascia which strengthen the posterior wall of the inguinal region, preventing hernia formation.
Yes, sir.
Defect in any one of them, you have a problem.
Yes.
Right? And based on this, you have the congenital theory of inguinal hernia formation. What's the congenital theory of inguinal hernia formation?
Sir,
you have heard of this term? You have not heard of this term?
Sir, I've not heard of this term, but
can you guess?
Sir, as the development of the human beings occurred, sir,
now you know the Frouchard's orifice?
Yes, sir.
Okay, so that's a weak area in the lower part?
Yes, sir.
Does everyone develop a hernia?
No, sir.
No. Why?
Sir, because there is the abdominal muscle weakening won't be present in everyone.
Because that is reinforced whenever there is a rise in the intra-abdominal
pressure. Yes.
Right?
Yes,
now,
sir.
what strengthens it? The arching fibers of the internal oblique and transalis fascia, they straighten up.
Yes.
And come and approach the inguinal ligament. That's number one. But what we don't understand, what we understand less is there's another thing which re-strengthens it. And that is the transalis facial arch, which comes and approximates to the iliopubic tract.
Okay.
Agreed?
Yes.
Now, suppose for a moment, let's believe that these fibers are high arching fibers. Or there is a congenital defect in the collagen which is there in transalis fascia.
Yes.
In both the conditions, it would give rise to a formation of a direct hernia.
Yes.
Right? So,
yes, sir.
You should know what a congenital theory says.
Okay.
And for the congenital theory of indirect novel hernia, this is the congenital theory of direct novel hernia. For indirect novel hernia, you know it. Processes?
Vaginalis.
Patent process vaginalis.
Yes.
So a congenital theory can explain both a direct and an indirect.
Yes.
But everybody doesn't agree to it. Doesn't agree. So you have both the acquired theories and the
congenital theory.
Congenital theory.
Okay.
Dr. Hitesh, over to you.
Yes, sir.
Can I ask one more question?
Yes, sir, definitely.
Suppose you have done an open herniography or a hernioplasty for that matter, and the patient comes to with post-operative neuralgia. Tell me the causes.
Sir, sorry, sir.
A post-operative neuralgia in a patient where you've done an open hernioplasty or an open herniography.
Sir, the causes of neuralgia would be electrocautery to the nerve, or the traction of the nerve, or the transaction of the nerve.
No, not nerve. Let's be more specific. Which nerves are we talking about?
Sir, ilio-inguinal, ilio-hypogastric, and the genital branch of genitofemoral nerve. Sir, these are the three nerves which are more commonly injured in hernioplasties, sir. Open hernioplasties.
Not in herniography.
Yes, sir. Like anterior approaches, sir.
So, to prevent injury to these nerves, what I have to be careful about? One, we already discussed, putting the suture. And be very careful that the needle doesn't include the iliohypogastric nerve. What else you need to do?
Sir, we need to isolate the nerve along its whole of the course in the inguinal canal and preserve it beneath the inferior flap of the external oblique aponeurosis.
So the most common time when you go liable to injure these nerves is when you're doing a dissection of the sac.
Sac.
That's the most common type. When you're likely to injure the genital branch, genitofemoral, or the ilioinguinal nerve, which are in close association with the cord. The iliohypogastric is not in close association. It is lying over the arching fiber. It's not with the cord. So you have to be very, very careful. Now, this patient has come to you with neuralgia in the post-operative period. You're very careful, but now, what do?
Sir, for initial period of time, we will give analgesics and anti-inflammatory to the patient.
What is the initial period of time?
Like, sir, for 2 weeks, sir.
2 weeks. Why 2 weeks? Why not 3 weeks?
Sir, we usually give trial for about 2 weeks, sir. If
there's nothing usual about it. There are specific definitions, my dear sir. For chronic neuralgia, there's specific definition.
Yes, sir. That is for
neuralgia, there's specific definition. So you have to stick to those definition. It's not something which varies from person to person. I may be not comfortable with the patient coming back to me after 15 days with a pain, and I may decide I like to do something. Would that be justified? Absolutely not. And there's another surgeon who keeps on waiting for 6 months and even more. Is that justified? No, that's not justified. So there has to be a time period when you have to decide when it has become a chronic neuralgic pain. Acute, yes, you can manage with analgesics.
Sir, more than 3 months. More than 3 months will be.
Okay. So after 3 months, what do? Patient
Sir,
still has come to you.
Sir, we can consider nerve block, sir. The femoral nerve block.
Agreed.
Sir,
okay.
and
which nerve block did you say? Femoral?
No, sir. Yes, sir.
I thought you said femoral.
Yeah, yes, sir, but it is not femoral, sir. Genitofemoral, sir.
Genitofemoral block. A very easy block to carry out. Not very easy.
Sir.
More commonly, which nerves would be approachable for a nerve block?
Sir, ilioinguinal.
And?
Iliohypogastric.
Gastric. Because they're lying more superficial in the region of ASIS. That is where it can be approached. That is one. Second approach?
Sir, we will consider triple neurectomy, sir.
Okay.
If it is not relieved, sir.
Right. So I wanted to know that word, triple neurectomy. Agreed. And that is why herniorrhaphies are probably inferior as far as neuralgias are concerned, inferior to mesh. But even when you're putting in a mesh, what do you have to be careful about? Even a mesh can give rise to neuralgia in an open repair. What do you have to be careful about?
Sir, like same, sir. While taking the sutures with the on the floor of, like suppose we are taking sutures to the conjoint tendon or the reflected part of the inguinal ligament, the ilioinguinal nerve might get trapped in between the mesh, sir.
Usually doesn't come into play. So iliohypogastric that is entrapped. And that is why what are the modified Leichenstein's repair now? Would you routinely like to apply sutures to the arching fibers?
No,
there is
sir.
a modification Leichenstein where they don't apply any sutures upstairs. They just put in a mesh, and that mesh is covering the arching fibers for about 2 to 3 centimeters. That again is a problem. Why? It is lying in close proximity to the iliohypogastric nerve. Can again give rise to fibrosis. So these are the practical problems that you can face with even with Leichenstein's repair. It's not the Leichenstein repair. Of course, it's a gold standard, but it's not without its own complications. You have to be very, very careful when you're applying the sutures and what type of sutures, because both are acceptable. You can apply interrupted, you can apply continuous. Right?
Yes, sir.
Dr. Hitesh, over to you.
Sir, I'm very happy that today we have discussed so many technical aspects, because by the help of hernioplasty, the art of dissecting hernia surgery has probably reduced.
Yes, absolutely.
And the teaching has also reduced, and the questions were very pertinent. I remembered my learning phase, and probably the boy has given a few correct answers also.
I think he's done
in spite of his less exposure because of COVID. He has entered the second. He is in the second year, and our hospital was converted to COVID. But still, this is very important thing as far, because in general, we will always go, most of our teachers, for pre-peritoneal or TEPP and all anatomy and these complications of laparoscopy. But these are the things which are very important. Once every 6 months, I also do shoulders repair to demonstrate these guys, particularly for young guy with indirect inguinal hernia, just to demonstrate what the skills were, and there has to be some dissecting skill. Putting a mesh is not important. Putting a mesh properly and proper dissection is very important. I'm very happy with your question, sir.
One more thing I'd like to say, that I have been very particular with my students that transalis facial anatomy is a must.
Yes, sir.
You're doing laparoscopy, you're doing open, doesn't make a difference. Even in laparoscopic examination, these analog that I was talking about are very clearly visible. You can see the lubric trad, you can see the transalis facial arch, you can see the sling. Everything is visible.
Yes, yes.
So entering the correct plane in a TAPP or TEP has to do with knowing the transalis facial anatomy. Absolutely. If you don't, you can't enter the correct plane.
Absolutely.
And if you have any bleeding, if you enter into the preperitoneal space, you are in the wrong place.
Yes, yes.
A simple reason, because the plane that we have to enter is an absolutely avascular.
Vascular.
That is to be remembered whenever you are entering in a TEP or a TAP.
Good.
Dr. Kanagvel, sir, would you like to come in?
Rajesh, sir, thank you, sir. I have been listening to every part of your discussion. It was going good. Thank you, sir, for joining us
I'm
Even
sorry
at the
for being late. My surgery kept on.
No worries, sir. I saw you joining just after 9. Thank you very much for joining us.
But you covered up the first part, sir. You answered so many questions and very nicely.
Yes, sir. Yes, sir. Yes, sir. I was watching all.
Technical.
Thank you very much, sir. Kavan, do you have any doubts or any questions to ask? We have the national faculty here. Would like to ask any questions for a clarification?
No, sir. Not right now.
Okay. Kanna, sir, are you with us, sir? Rajiv, sir, any comments from your side?
No. I think Professor Sinha's conducting this exam was excellent, and Kavan has done very well. Well done.
Yes, I think he's done.
One advice I like to give Kavan, as my student, is he must know when to say no, sir. I don't know.
Yes, that is important.
He was always throwing some 2-3 questions which probably never thought.
10% of the questions.
I don't know is ultimately a correct answer. This is what I say to my students.
Yeah.
Okay.
It is not necessary that you know everything on the day of exam. Nobody knows.
No, nobody knows. Even we don't know.
Even we don't know.
But you must learn. I don't know, sir.
Okay, sir. Yes, I will.
Very important point, sir. Thank you, sir. With the permission of the faculty, I thank all of you for joining, especially Hitesh sir and Srinivasan sir for kindly contributing the PG. Both Dr. Prabhu and Dr. Kavan did justice for today's presentation. I'm sure we had a lot of new questions for Parotid coming up, and Groin has been a full revision after almost 1 year of discussion we had in our forum. Thank you very much. We look forward for having you on the coming Friday. Mostly it will be mass abdomen. Rajiv sir, any of your PGs, if they are keen in contributing, please guide them.
Will do, sir. Definitely.
Sir, Rajiv sir, I want to ask one query regarding previous case.
Yes.
Whether if that was not a absolutely fixed mass and relatively smaller tumor, and as there is history of superficial parodectomy, should we think of any other differential diagnosis as from a history and examination point of view, as there is history of superficial parodectomy documented, and on examination there is no deep lobe involvement? Should we think of anything arising from mandible or not as a differential diagnosis?
So, Dr. Hitesh, I think recurrence of
yes, sir.
tumor post surgery is a very common, and I know it's the second most common surgery tumor.
No.
So,
yes, sir.
So I would keep it as the first. Of course, I mean, a second tumor like a lymphoma can occur, but I would still
just as a differential diagnosis, particularly when if the facial was not involved. Here it was involved.
Either way.
Okay, sir.
Either way.
Just a thought came in my mind, but I thought I'll ask at the end.
I'll just talk to you after 10 minutes.
Thank you, sir. Can we call it a course faculty, sir?
Yes.
Thank you very much, sir. Thank you all the friends who are watching in the YouTube. We look forward to meet you in the coming week. Good night, everyone.
Good night, everyone.
Thank you very much.